Welcome back. My name is Dr. Forrester Dean, and I'm here with my friend
Venzel.
And so today we're going to talk about kind of a complicated, we're not exactly sure how we're going to do this, but we have new mics,
Yep.
which we think are too big, but we're trying to improve the sound because we get tons of complaints about, we don't get any complaints, we work hard. Okay, so the idea today is that we're going to try to discuss this resistance versus stimulus in movement, how the body generates energy to produce work, and we call that like observable work, right? So, and you can see it happening, right? That's an action. And then we're going to talk, so that's like the stimulus, right? So I was like, okay, so move, boom, right? That's right. So your brain tells your body to do something, right? So, but then there's also resistance, right? So there's also a stop mechanism in movement. So if I say, hey, I'm gonna like I'm post down, right? So I'm gonna post down, and I'm gonna get that ground force reaction. Is gonna kind of push back. That's closed chain. But now what about something like, let's say I go to block you and you're too far away and I don't get anything, but I know I have to stop. I know I can't just keep flinging my arm around forever. So at some point I have to be like, oh, I can't block you, I can't reach you.
Can't keep searching.
Searching, we're going to talk about that again. So just follow through with us as we try to break this down. So the goal here at the sort of the end of the conversation is to kind of break apart not necessarily resistance versus stimulus, but the wrong kind of a therapy, like a physical, and I don't mean physical therapy, I mean a physical type therapy, a movement therapy instruction that exists now, and then what we're going to propose that's kind of the improved, dialed up, more knowledgeable concept.
Which
right?
is also more engaging. It has the client or the patient, they play a bigger role in what they're doing.
Exactly. And that's key. So remember what he just said. Okay, so let's talk about force, let's talk about power, let's talk about that. So we're going to get into a little bit of physics first, but we're not trying to bore you, and we just need to get past this step because when we use words, we need to make sure we understand what we're talking about. We need to know the definition. So if Venzel is working on me, like let's say, like right now I've got this knee issue, right? And I just sit on a chair, sit on a table, and he goes about moving my knee or tells me what to do, right? We need to understand that more measurably, right? So we talk about, so what's force? Force is mass times acceleration. Right? So if I'm going to apply a force to you, the mass is the mass of my hand, right? And the speed at which I move, right? So there are two accelerations. There's this acceleration, then there's acceleration of gravity, right? Pushing down. If gravity is more, I would miss and go down.
Exactly.
Right? So as I'm pushing forward, I'm actually opposing gravity so that I land here. Okay? Now let's talk about power. Okay, so power is that force times velocity, right? And so we could also understand that as work over time times velocity, right? So power is, in the end, it's mass times acceleration, which is the force, times velocity. And we talk about velocity, we're talking about, remind me?
Velocity has to do with the direction of the applying force. So if you're using velocity, how gravity affects the velocity of where that speed of
so it's like a vector.
Yes, literally, it's a vector of where you're driving to.
Yeah. So when we're doing like a physical type therapy instruction, we're not so concerned with the exact direction because there are actually so many angular changes in the movement. We could never do all of that math. So the point of this is that classical physical type therapies don't ever consider force, mass, acceleration, velocity, power.
Yeah.
It's just, hey, do this thing 10 times, right?
Yeah.
And so the idea primarily is reduction of pain and increase in strength. That's pretty much the world of those physical type therapies. And that's great. But what it doesn't do is address stabilization, cognition,
Proprioceptive cueing, being able to know where you are spatially and how you interact in that space.
including horizon lines.
Exactly.
Right.
Exactly.
Acceleration, deceleration, all those things, right? So what we want to do is kind of construct something more comprehensive that a therapist could understand while they're doing it. So we're not going to show you a physical therapy or a physical type therapy right now. What we're going to do is kind of blow it all up. I don't know if you've ever seen like that movie Chef or Chef Show. So it's, they've got a food truck, right? So in Chef Show, at the beginning, they talk about what they're going to make. And then the truck kind of rattles, it's an animated truck, and it kind of rattles along, and it goes boom, and all the bowl of ingredients all blows out. And then they label all of the different things that are in that dish, and then all the things come back together. So what we're going to do is we're going to kind of Chef Show this idea of a physical type therapy. So we're going to put physical type therapy in that bowl, and we're going to put it on our food truck. We're going to jiggle it around, and we're going to boom, and we're going to blow it all out. Okay, so here's what we're going to talk about. We're going to talk about resistance to stimulus. What's the difference? So resistance is a reaction, right? So when we're doing a physical type therapy on a patient, we want to get them to react. We don't want to just have them cognitively do something. So, I say same thing, knee. And Venzel comes over and says, hey, Dean, how are you doing? I'm like, oh yeah, so I'm here for my knee. You do an exam or whatever, right? And like, okay, first thing I want
and I have you sit down.
Yeah, we can't kill him twice with that. So he said to me, if the patient comes in walking, their therapy should be done standing.
Exactly.
Not sitting or laying down. Yeah, we said that before. But it's a great point. Okay, so if he says to me, yeah, so I want you to, even standing, so I want you to, just do a little marching drill with your knee, right? So I'm not responding or reacting to a verbal cue from you. So let's do it like we do when we're doing Core X. So I'm ready, right? And then, so you tell me what I'm going to do.
Okay. Sit. Relax. Sit. Relax. Sit. Relax. Sit. Hold.
Oh, so, and this, right, so we didn't practice this like everything else. So what happened is I got used to your rhythm.
Yep.
And I started to predict, right? And I didn't sustain like he said. So that reaction is key to a therapy, right?
And he had to be aware and conscious. Once he found the rhythm, it went to what? Autopilot.
Right.
We want you to be cognitively aware of what you're doing at all times.
In that moment.
Exactly, because that keeps you out of an injury.
Right. So what we're looking for is that reaction so that when he's like, okay, so stop, right? I go into stabilization, right? And so what this kind of a therapy is asking me to deal as a patient, I have to deal with what you're throwing at me.
Yes.
And if what you're throwing at me is just, hey, do this 10 times, I'm not going to put an ankle weight on you, do it. I'm not responding to anything. There's no uniqueness, right? So then I think that potentially could delay the healing process.
Yes.
Okay? Yeah. So we're going to talk about now the exam. We always say this, the exam is the treatment plan.
Exactly.
So if you're going to do an exam on your patient, say, again, it's a knee problem or whatever it is, the way you exam, make sure your examination represents a kind of a treatment plan. So the way you exam is the way you treat.
Yes.
Okay, and we've said that before. Okay, so and we have a couple other notes like about coupled motion, right? So remember, for example, if you're giving a patient a drill, let's say, TL junction therapy, and they're tipping to the side, just, remember that by that concept couple motion, you're also getting, when you get lateral bending, you're also getting a vertebral rotation.
Yeah.
So remember that, you're getting kind of 2 for 1, and that's the goal. Okay, let's talk about quickness, suddenness, acceleration, and deceleration. So this is where this is going to get really interesting, okay? So we're going to kind of break off of that classical motor-driven explanation. Okay, hey, I want you to lift your legs to the side, or whatever it is, right?
Yeah.
So this could be a potentially an exam. Now remember, the exam should help the therapist or the examiner understand the patient, but the patient should be learning from the exam as well, understand how that's working. So we practice this a little bit, and this is seem pretty unconventional, but I'm actually going to throw the ball at him.
Oh no!
Right. So this is just a little 45 centimeter Swiss ball. And so, the idea here is that, now this isn't specifically for his knee, but we'll get into that, okay? So what I'm going to do is he's just going to come into like a neutral position. You can say like a core neutral position. And I'm noticing that his, because he knows how to get into core neutral, his shoulder alignment here is already in scaption. So if he was back here, just move back. So that's completely lined up. 0 degrees, he's just going to move forward to 30 degrees, right? And that's going to move his scapula into more stability. So what I'm going to do is I'm just going to pass the ball kind of at his shoulder. That doesn't hurt, right?
No.
Okay, so let's say he does have a complaint. Let's say it's the other shoulder. I wouldn't start by throwing the ball, but there's no good reason why you shouldn't. Right, so we're going to do both sides, but just for today. So I'm just going to kind of bounce the ball off of him, and I'm just going to ask him, Venzel, can you just be stable, pull your belly in, right? I'm just going to tap the ball here, and then I'm going to notice if I stop tapping, did he, like in the example of me pulling the knee up and I put it back down, I'm just looking to see if he automatically comes back when there's no stimulus. So we only want him reacting to a stimulus. So I'm just going to throw it out there, okay, audience. What am I testing? I'm testing right lateral flexion by reference. By reference. And we've said this before.
Exactly.
Okay? You don't have to physically see the patient move in order to understand that they're contributing to the drill. So when he doesn't move, that's stability. That means that the joints are inflexible in every way, right? Inflexible. So he's locking in. And so we were just talking about this, and we're going to throw this out at you later, not today. That's negative gamma gain.
Yeah.
Stability, right? That kind of blew our minds. We kind of went through that. We'll explain it another time. Okay? So because I'm loading him this way, he's staying stable. He's preventing himself, just tip a little left. He's preventing himself by tipping left when I hit him with the ball by staying in the center. Right lateral flexion by reference. Okay? So, and again, a physical therapy doesn't mean that your athlete or your patient has to demonstrate motion through a range of active range of motion. Okay? So that's, okay? And if I wanted flexion from the other side, I just go to the other side. So this is not so much about what's injured. This is about me understanding his ability to stabilize and deal with the deceleration and reaction. Okay? Now, I'm going to move over to here, and I'm going to bounce here. That doesn't hurt, right?
No.
Okay, so what are we getting out of that? By reference.
Yeah. It's rotation.
Left rotation, right? Because you would be going back if this was a force, and you are left rotating, right? So that's TLJ, right? So I don't have to put him on the floor and do dead bug and blah, 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 right? Because you've got ground force reaction working for you. So then if I come back here, by reference, that's resisting into right rotation, okay? Yeah. So go ahead and relax. Now, go ahead and put your hands back up, and then Venzel, this time face me.
Okay.
Yeah. Good. Hands up, neutral. Good. And then bring your hands a little closer together and up. Yeah, a little higher here. So, and together. Yeah, so I'm just going to kind of bounce, open your fingers big. Yeah, so I'm just going to kind of bounce off him here like this. So notice I'm trying to go perpendicular to his palm. And then, right, so I started to go, and then I'm looking to see if he just automatically pushed with no stimulus. So go ahead and relax. So what we're saying is that a true, improved physical type therapy needs to ask you to respond uniquely to every single stimulus, whatever that happens to be, right?
Exactly. Yes.
Yeah, so if I just, right?
Yeah.
Now, he didn't know that was coming.
And it naturally pulled me and sent me into rotation.
Right, and then you responded and react to that, right? So what we're saying is that a different way of understanding how to provide or work with acceleration and to deceleration isn't necessarily to say, okay, you know, core neutral, you know, just quick, right? So I'm producing all the work. I'm not responding to anything, but I am responding if you cue me verbally. So we don't want to forget about those verbal cues, right? So another way to do this would be, I'm going to close my eyes, and he's just going to tap me on the shoulder when I'm supposed to lunge. Good. Yeah. So, and I noticed I don't know if you saw this, but you tapped me in different places.
Yep.
So I didn't get used to just,
stimulus,
zeroing in my laser on one specific spot. Okay. So what we like about this drill, specifically with the Swiss ball, is even if I'm just tapping you here on the shoulder, isn't that knee also dealing?
The whole system. I feel it throughout my whole body. My whole chain is activated and it's cued. I felt it. When I felt you tapping the shoulder, I even felt it on the opposite side. So I had gained stability through making sure I was in scaption. And when I felt that force, that opposing force, I just went into scaption a little more, and it helped me stabilize my shoulders.
Right. So what we're looking for is a whole body response to a therapy type drill, not one in isolation. So this, we've talked about this before, this becomes a problem when you get a prescription for someone who's got a knee injury, right? And then the whole, the therapy has to encompass the knee, and you can't drift to other parts of the body. Well, I don't know, was the insurance company there when you were tapping them with Swiss ball, right? So we want you to be a little bit more creative. So in this example, come into core neutral. Just face the folks there. Yeah, that's good. Good, core neutral. And so I can just kind of come around and go everywhere, right? I'm going to go off his elbow. I'm going to go off his wrist. He's going to stay cued, right? Anywhere. I'm not. What area can't you bounce the ball off of, right? And relax. Good. So even just that little drill, like you could break a sweat.
Yeah.
And he didn't move. He didn't demonstrate action, but you were definitely working by responding, right? And then, of course, your favorite word.
Proprioceptively cued.
Right. So proprioceptively, he was listening to his whole body because the drill was unexpected, and it could be anywhere. Now, I probably wouldn't hit you,
Yeah.
throw it at your head, but the idea is even if it's just a focus of therapy to the knee,
You can treat the whole system.
you can treat the whole system, but the whole system also has to be awake and alert. Remember readiness and awareness?
True.
Right? So I need to cue his whole body. Now, in some therapies, they might have you like walk on a treadmill or something, but that's all self-driven. It's not responsive, and there's very little unique proprioceptive feedback, right? Yeah. So I just oscillated his body. You got that acceleration into deceleration that we love so much. Okay, so now let's talk about the difference between a ground force reaction therapy and a non-ground force reaction therapy. So ground force reaction, I've been saying it that way for over 25 years.
Yeah.
You might know it as ground reaction force.
Yeah.
Okay, so I didn't like that, so I put the words around the other way. Ground force is one thing, and the human reaction is the other thing.
Yes.
And they happen in that order. That's why I don't like ground reaction force.
Because that and ground reaction force, it's talking about how hard and how stiff the ground is.
Exactly.
Granted, we're borrowing stability from the ground, but we're also applying a force to the ground.
Right.
So, and it translates back up to us and
Right.
how our spine and how our body oscillates.
Yes, and in the definition of ground reaction force, it is the responsive force of the ground into the body. But what we're saying is we need to take it from there and dump it into the whole body. You can't forget that there's a whole human involved in this.
And it's, exactly.
So ground reaction force is I drive down, the ground drives up. Ground force reaction adds the proprioceptive response of the person to the brain, right, for future work. Okay, so and let's just say, I'm just going to say it over and over. I'm not picking on physical therapists, I promise you. But if I have a knee problem, I need to drill it by stimulating it through ground force reaction.
Yeah.
That's closed chain. It is literally impossible. It's literally impossible to get a speedy, expedited, effective, efficient
treatment plan.
Right, treatment plan and happy patient if this is dragging out forever.
Yeah.
So I'm just going to say, if you've got 6 to 8 weeks, 12 weeks, 16 weeks of therapy budgeted for a knee, I'm going to say, if you could do it in 2 lessons, why wouldn't you?
Yeah.
And then you can get a new patient in, and then people aren't waiting 6 to 8 months to a year to get in for physical therapy. So if I can just, kind of start to wake up that knee a little bit. Okay, so I have a sprained medial meniscus, lateral collateral ligament, and a Baker cyst on this knee right now. Okay?
No problem.
It's not a problem. Okay? So that's a sprain. That's not a strain. It's two sprains. So the demonstration is, it's not about is it painful, is it not painful. The issue is we've got to provide ground force reaction through this knee to stimulate all the properties of positive and negative gamma gain, proprioception, muscle spindles, Golgi tendon organs, as well as the muscle. We can't just focus on muscle gains.
Yes.
And elimination of pain.
And that's literally the difference between the observable and the unobservable work.
Say it again.
Happening. It's the literal difference between the observable and the unobservable work that's happening, which
What's the difference? Tell them what's the difference.
The difference between the observable work is something that you can visually see happening, like them lifting the knee, putting the knee down, reaching back. Now, the unobservable work, would be when I was in core neutral and I was being tapped, all those micro shortening and lengthening of my muscle fibers that were going on that you could not see were happening. And that was where I gained stability, which we would call negative gamma gain.
Right, which is not so observable.
Yeah.
So, and we've said this before.
But they are both measurable, though that's the key. They are both measurable. So
and can be demonstrated.
Exactly.
Yeah. So a bunch of new words we're trying to throw in here. Okay, so what I'm saying is that if you're going to provide a therapy drill in this new updated version, we're saying please provide ground force reaction. Don't focus on whether it produces a episode of pain or not.
Yeah.
Because that's not the focus. The focus is to try something new, this quickness, this acceleration into deceleration into a ground force reaction. So for example, if I'm going to come into, say, he's like, hey, can you do a forward lunge, right? And then I step here, right? Now notice my whole body translates. My whole body translates here, right? Forward and down, okay? That's ground force reaction, right? Right? Yeah. Nice. Now, if I just go like this, that's foot searching.
Yeah.
Right? So because I'm not translating my mass, my whole mass is getting the experience of that ground force reaction, vibration through my whole body, waking up my entire proprioceptive antennas. If I just foot search, right, I'm not getting that ground force reaction. And I'm saying that foot search is the same thing as sitting in a chair and going like this.
Yeah.
To therapy
you
and
change the closed chain to open chain.
Right. So what's different is that my knee, my whole body is not responding to that quickness, that suddenness, and that load. So what we're saying here is, point is please add responsiveness. Like in our example, we just throw the ball at the patient, right? It's kind of fun, as long as you don't hurt them, right? You tell them what you're doing. Have them respond to verbal cues and or tactile cues with their maybe eyes closed or open or whatever. Have them respond in some way. Okay, next. Producing outward forces is classical physical therapy.
Yeah.
Outward forces. Okay. Hey, I want you to do a push-up, or I want you to do, angel wing on the wall. Right. That's what Venzel was saying. Those are visible.
Yeah.
Right. Outward forces that are designed in the brain of the patient and then go outward. So what I'm saying is, what about if instead of that, what if the patient has to respond to a drill or a movement, right? So we could do the same thing. Let's say we're going to do, face them, angel wings, right? So you're just going to, let's say you're on the wall, or just, so we're working on his shoulders. He's going to drop his arms down. He's going to lift his arms up. He's going to drop his arms down, lift them up. So that's sort of the classical way, right? So let's say he has a bit of a frozen shoulder, and we're just trying to get him to reach up a little higher, right? And there might be a limitation of pain. Okay, so now I say, all right, so I want you to shoot your arm up, but instead of lifting to the side, you're never going to believe this. If you bring your hand here and go straight up, all of a sudden you have more range of motion. So I'm taking that class, yes, right? And why does that work? Because the acromion isn't banging into your humerus on the way up. When he comes up to the side, he's limited by his acromion, right? So you can't do that quickly. But when he brings his arm to the front, he can rocket his arm all the way straight up. So now we can add that quickness. Now we can add that suddenness, right? So I'm going to have him respond now. Okay, so I want you to reach up as high as you can. So start with your thumbs at your armpit. Venzel, and go. And then bring it down, go. And bring it down, and go. And bring it down. Notice how, we could do this in slow-mo, but I'm seeing his body kind of jar, right?
Yep.
Now, just right, go. Just right, go. Just left, go. Just left, go. Left, go. Right, go. Good. Now, when he does it asymmetrically, you actually get more vibration, right? Because the two cancel each other out. There's some vibration, but there's more when it's done asymmetrically, right? But you're feeling it, right? You feel that quickness and that suddenness. Now, when there's quickness and suddenness, it's going to bypass pain.
Yeah.
The pain signal can't keep up with that vibration or that quickness or that suddenness. So all of a sudden we have gains in an active range of motion, and he's responding. Okay? So now I'm going to have him do the same thing. So I'm just going to cover the front of his shoulder, his little bicep area here. So just right side, go. Just right side, go. Just right side, go. Just right side, go. Now I'm giving him some proprioceptive feedback. Now, I'm not necessarily pushing down on him. I'm just giving him a little bit of a barrier that he has to deal with as he raises his arm up. And that's distracting your brain, isn't it?
Yeah.
That's also going to bypass pain. Pain signal can't keep up with that. Go ahead and relax. Okay? So what we're saying here is add a dimension of unexpectedness somehow in the drill.
Yeah.
So in this one, it was this asymmetrical right, left, right, and we're kind of building the story, and we're adding the acceleration and deceleration that we just talked about previously. Okay, now what about what then he already said this. You are responding to an inward force.
Exactly.
Right. So this is coming at you, and you have to deal with it. Right. Now, you can be doing a drill. It doesn't matter what it is. He could be doing a knee hike. Right, let's try it. He could be doing a knee hike. Yeah. Good. Yep. And you don't even need to hold. You can just like pulse. Yeah. Pulse. All right. So what I'm saying is, and I didn't hit you hard, but it was unexpected. Okay. Now that you know what the drill's about, right? Okay, go. Yeah. Go. 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 Okay, so we're doing hip flexion rehab, and I'm having him respond to, that's good. You look great doing it. I'm having him respond to an inward force that's adding your cognition about stability.
Yeah.
Right? While you're doing it. So why does that matter?
Specifically, why it matters is because, one, it's helping me tune in into every single stimulus that's happening.
All of your antennas are up all over your whole body, right? Not just, right?
Yeah, and get a little sneak peek about that that relationship between stability and mobility, and how that ties into it. That's for another video.
It's coming.
It's coming though.
Yeah. We're going to change again everything. Okay, so what we're saying is in the classical PT model, it's primarily efferent, right? Operations. It's top down. It's, hey patient, please do this observable thing.
Yeah.
So what we're asking you to do is say, hey patient, I want you to do this observable thing, and I want you to react and respond to doing those things as cues, and I want you to respond inwardly to proprioceptive response to stability and dealing with forces that have nothing to do with that specific drill or that specific rehab. Right now, so we're going to chart him for doing, like an A step or whatever for hip flexion, but I'm here. I'm your therapist. Why can't I perturb you a little bit, right? Get into that, wherever it is that seems reasonable, right? Okay, so what we're doing is saying add afferents, add afferent stimulation, proprioception, so that they have to react, they have to respond, and it also makes it more real.
Yeah.
Right? So, for example, you're walking along, and you stub your toe, and you start to fall. That's that reaction. There's no exercise for stopping a fall.
Yeah.
But there is training for learning how to pull back into stability so that you don't wipe out and turn a fall into a broken shoulder, a broken elbow, or a hip displacement, right?
And in previous videos where we talked about that readiness and awareness, this comes in key because you have to be able to, It basically, long story short, it turns you into a better listener for your body.
Yeah, I like
You
that.
listen to your body better. This way, you know when you can make a correction, you need to kind of externally rotate your femur to get a little more stability in that step. You felt that step was off, you making corrections. This is to help you be more accountable to you.
Yeah, and if you think about it, the the common drills that are in that classical physical therapy environment never overlap into sports because they're so isolated.
Yeah.
Right? All sports activity is compound angles, compound movements, multiple dimensions of myofascial slings interacting unexpectedly, suddenly, changing direction, looking for a horizon line, looking for, if you're going to block, if you're going to be defensive, offensive, all that's happening. If you just minimize that down to a single joint, self-actualized exercise, you're missing 150% of what that person is about.
Yeah.
So the words we're going to use here, so classical physical therapy is more focused on restoring the athlete or the patient. And what we're saying is versus construct.
Yeah.
Construct your patient, construct your athlete, build them in with everything.
Yeah.
Right? Not just making the front door swing again, right?
Yeah.
Greasing the hinges, but making sure that door is framed solidly and the whole house is stable and safe, right? The whole thing is built, not just a squeaky door hinge, right? Okay, so that was kind of long-winded, and we're out of time. So, ponder on this and please catch up with us because I think we're going to do Gamma Gate next.
Yeah.
Because this really
ties in with it.
Yeah. And again, please email us, contact us, anything with your questions. Thank you so much, Dr. Dean.
Venzel. See you guys again.
Thanks so much.